Thank you, Chairperson, for the introduction. So, first of all, I would like to thank organizers, Dr. Pudar sir, Dr. Anshu ma'am, and Moinak and Dr. Arya, so for giving me this opportunity to speak on this topic. And so it is actually difficult to speak on this topic in front of the stalwarts of who are working in this field. So, but I will try whatever best I can. So this will be my overview on non-cirrhotic portal hypertension. So presentations of liver disease, as we all know, are hepatocellular, cholestatic, organomegaly, and portal hypertensive. So various etiologies are there in each categories. So today we will be focusing on the portal hypertensive presentation, where there is presentation as isolated splenomegaly, hypersplenism, preserved synthetic functions, absence of jaundice, and the common etiologies here are EHPVO, non-cirrhotic portal fibrosis, and congenital hepatic fibrosis. So there is definitely some overlap between with the hepatocellular, cholestatic, as well as the organomegaly presentation. But with isolated portal hypertension, these three etiologies come into picture. So definition of portal hypertension from the adult data, we all know that it is defined as when the portal vein to IVC gradient is more than 5 millimeter of mercury. So various causes are prehepatic, hepatic, and post-hepatic. So hepatic causes are basically cirrhotic, and prehepatic is extrahepatic portal venous obstruction, and hepatic causes, the pre-sinusoidal one is non-cirrhotic portal fibrosis and congenital hepatic fibrosis. So again, the same thing showing diagrammatically here. So HVPG is the gold standard. So hepatic venous pressure gradient, that is the difference between the free hepatic venous pressure and the wedge hepatic venous pressure, and the free hepatic venous pressure is the gradient. So when the gradient is more than 5, so is actually portal hypertension. And so in cirrhotics, the varices develop when this pressure is more than equal to 10 millimeter of mercury. So with HVPG, we can differentiate cirrhotic and the non-cirrhotic causes. That is, when the HVPG is normal, it is EHPVO, when all the pressures are normal. In non-cirrhotic portal fibrosis, which is the pre-sinusoidal cause, it may be just slightly higher. It may range between 6 to 10 millimeter of mercury, whereas in sinusoidal causes, that is cirrhosis, the HVPG will be high. And in the post-hepatic causes, that is hepatic venous obstruction, and the cardiac causes, the right atrial pressures will be high and all the pressures will be high. So ultimately leading to the gradient, which may be just normal or near normal. So again shown in this diagram. So from portal vein to hepatic veins via sinusites, the obstruction in the portal vein is EHPVO, whereas if the obstruction is at the pre-sinusoidal level, so that is portal non-cirrhotic portal fibrosis, which is also called as obliterative portal phlebitis. So as we all know from the basic concept that how to differentiate cirrhotic and non-cirrhotic portal hypertension, in cirrhosis, there will be the history of jaundice, decompensation, coagulopathy, shrunken liver from irregular liver, growth failure, whereas in non-cirrhotic portal hypertension, the everything related to liver span, and the liver function test, they will be normal, but growth failure is a common thing which will be seen in both cirrhotic and non-cirrhotic portal hypertension. So this is the approach which we have to follow, that a patient who presents with variceal bleed or just found to have varices, splenomegaly, thrombocytopenia, so then we should suspect portal hypertension, and then we should answer two questions: whether there is evidence of chronic liver disease, and whether if the patient has bled, whether the bleed is poorly tolerated or well tolerated. Poorly tolerated means in terms of development of ascites, encephalopathy, jaundice, coagulopathy. And if the answer is yes, so we are dealing with cirrhotic portal hypertension. If the answer is no, then we are dealing with non-cirrhotic portal hypertension. Then we should go for ultrasound Doppler for the portal vein patency. If there is cavernoma, so then it is EHPVO. And if there is no cavernoma, so then possibly we are dealing with non-cirrhotic portal fibrosis or CHF. So about etiology in comparison to the East versus Western data. So EHPVO constitutes one of the commonest cause, although this is a bit older data. From the recent data as we see at our institute, now we see more of cirrhotic causes of portal hypertension in comparison to non-cirrhotic. So there is difference among centers, and so there is referral bias. So variceal bleed is almost is seen in EHPVO more commonly than cirrhotics, and there is more high risk of mortality in cirrhotics in comparison to EHPBO. So again, the data from West has shown that the variceal bleeding rate is around 6 times higher than in non-cirrhotic, and this bleed is predicted in cirrhotics by presence of splenomegaly and with low albumin, whereas in non-cirrhotics it is predicted by splenomegaly and with low platelets. So this is our iLBS data, whereas in around 135 bleeders, we have seen in 2/3 of the cases, there was cirrhotic portal hypertension in contrast, and 1/3 had non-cirrhotic portal hypertension. So how should we differentiate the non-cirrhotic causes from cirrhotic causes of portal hypertension? On the basis of age of presentation, EHPVO presents early, non-cirrhotic portal fibrosis presents in 3rd to 4th decade, and a small proportion of patients can present in adolescence. Congenital hepatic fibrosis is again a disease of 1st decade. Decompensation following a bleed or otherwise is present in cirrhosis, whereas it is not seen in non-cirrhotic portal hypertension. LFTs are deranged in cirrhosis and congenital hepatic fibrosis. The liver function, the liver size is enlarged with a firm, hard liver in congenital hepatic fibrosis, whereas it will be shrunken in cirrhotic portal hypertension. Splenomegaly will be massive in non-cirrhotic portal fibrosis. Histology will show congenital hepatic fibrosis in the form of wide fibrous bands and dilated bile ducts, whereas in non-cirrhotic portal fibrosis, there will be obliterative portal venopathy. So portal veins will be sclerosed, atrophic portal tracts, and there is approximation of portal tracts in non-cirrhotic portal fibrosis. On ultrasound Doppler, so there will be cavernoma in EHPVO, whereas in cirrhosis there will be dilated portal vein with slow reversal, and in congenital hepatic fibrosis you may find renal cyst or cystic dilatation. So this is the diagram showing the natural history of NCPF, which is also called as idiopathic portal hypertension and EHPVO. So these are the various things which are seen in the natural history of both of these conditions: splenomegaly, variceal bleed, hypersplenism, growth failure. So these are seen earlier in EHPVO and later on in non-cirrhotic portal fibrosis. And whereas the portal biliopathy is more often seen in EHPVO and is less often seen in IPH, whereas parenchymal extinction followed by decompensation is seen often in non-cirrhotic portal fibrosis later on in life, in contrast to EHPVO. So from here on, I will discuss some specific issues related to these conditions. So what about portal biliopathy in EHPVO? So this is one of our patient, 8-month-old infant who was born with birth asphyxia, with NICU stay, umbilical vein catheterization, splenomegaly. And so upper GI showed large esophageal varices with gastric varix. So he was taken up for prophylactic EST. And at 11 months of age, he presented with biliary obstruction, and MRCP was suggestive of portal biliopathy. So this is the MRCP image of this child at 11 months of age, showing significant dilatation and ectasias of the intrahepatic and the extrahepatic bile ducts. So what about the portal biliopathy changes? So these changes are seen in around 90 to 95% of adults with EHPBO and also in children. So they are more commonly seen on the left side rather than right side, and they are in the form of ectasias, indentations, caliber irregularities, angulations, and CBD stones or filling defects. So these are two studies, one from SGPGI, so where 92% patients had portal biliopathy on the basis of MRC and endoscopic ultrasound. And another study from PGI Chandigarh again showed 100% presence of portal biliopathy changes on MRCP and endoscopic ultrasound. And from SGPGI, it was shown that the SMV non-patency was a strong predictor of severity of the MRC changes. And so this is the approach. How should we approach a child with or an adult with portal biliopathy? So we should look for whether the patient is symptomatic or asymptomatic. And with asymptomatic, we should look up the biochemistry in the form of elevation of alkaline phosphatase and GGT. If the patient is symptomatic, then there is an indication for ERCP, for stone retrieval, or for stricture and dilatation. And then subsequently, if the changes persistence of the changes may be an indication for shunt surgery. And subsequently, after the shunt surgery, if the changes are persisting, because some of the changes are related to the ischemia rather than actual compression, so then a proportion of these changes may require a staged surgery in the form of shunt surgery followed by hepaticojejunostomy. So what about ectopic varices? So this is one of our case. So this was a 2-year-old boy who was born term, and there was history of again history of birth asphyxia, ICU stay, and there was sepsis, UV umbilical vein cannulation, and at 1.5 years of age, he had multiple episodes of upper GI bleed, for which he underwent and upper GI endoscopy and colonoscopy, but there were no significant varices. Small varices were there, but they were not significant. So he was managed just with octreotide and repeated blood transfusions. So when he came to us, so his growth parameters were normal, spleen was palpable. So he had so he had these issues, multiple episodes of bleed, which was upper versus lower GI bleed, and splenomegaly. So he had portal hypertension, which was EHPV, which was confirmed on ultrasound Doppler. On investigations, the platelets were normal, hemoglobin was low, and ultrasound showed cavernoma. So, and Meckel's scan was also done because he had multiple bleeding episodes, which were more likely to be lower GI rather than upper. So Meckel's scan was also negative. So these were the colonoscopy pictures, upper GI pictures, which showed just a small esophageal varices without any red color signs. So subsequently, CT scan, CT angiography was done, which revealed ectopic varices in the region of the hepatic flexure. So, but nothing was found on the colonoscopy. So this patient had colonic varices. So how to deal with these ectopic varices? So the upper one, the type 1A to type 3A. So these are without any obstruction in the portal venous system with development of collaterals, whereas type 1B include so these are the occlusive form of the ectopic varices. So our patient was lying in type 1B, where there was occlusion in the portal vein, and there was development of the portoportal collaterals rather than portosystemic collaterals. So portoportal collateral is type 1B, whereas type 3B is the portosystemic collateral. So this is the protocol, how to manage these ectopic varices. We have to classify whether this is occlusive type of ectopic varices or oncotic type, that is patent portal system. So with occlusive type, we have to the options are either decompression or to recanalize the portal wherever the occlusion is there. And if it is unsuccessful, so then the patient can be considered for a shunt surgery, or and if the system is patent, so then again the variceal portion can be either embolized with a BRTO, balloon retrograde transvenous obliteration, or decompressed by again with a shunt or with the tips. So here in this particular case, we considered the options like to decompress the system, or to do the mesorex shunt, tips, portal vein recanalization, or a typical shunt surgery, or to resect the varix, or variceal embolization and colonic resection. And so out of these options, we considered with we discussed with our intervention radiologist about tips or portal vein recanalization, whether it is feasible or not. So they were not feasible. We also looked up for the patency of the patency of the rex veins. That was also not possible. And also when we discussed with our surgeons, the option of colonic resection was also not there. So he was taken up for portosystemic shunt surgery, and then after that he was with splenectomy, and he was fine after that. So what about splenic issues in non-cirrhotic portal fibrosis? So this was another case, 18-year-old boy who was NCPF, bleeder, and subsequently he was on endotherapy sessions. The last endotherapy showed small low-risk esophageal varices with gastric varices GOV1. On examination, he was bit underweight with significant massive splenomegaly, 18 centimeter below costal margin. Rest of the systems were normal. And on lab evaluation, there was hypersplenism. So this particular case had issues related to spleen. Spleen, underweight, he had recurrent fever, and he had early satiety related to spleen, and also there was pain in the left upper quadrant. There was no evidence of parenchymal extinction. Liver function, synthetic functions of the liver were normal. So what were the options? So we considered the prophylactic surgery. So what about surgery in non-cirrhotic portal fibrosis? So this is the data from AIMS. So where 45 PSRS operations. So they were analyzed, and it was found that 3 patients subsequently had bleed. One had variceal bleed, 2 had duodenal ulcer bleed. There were 2 late deaths. One was related to renal failure. And important point to note here is that almost half of the patients had delayed morbidity in terms of portosystemic encephalopathy, glomerulonephritis, which is related to the shunt. 2 had pulmonary arteriovenous fistulae, and 5 had ascites requiring diuretics. So only 53% of the patients were symptom-free on follow-up. So prophylactic surgery without any previous bleed is safe in preventing the variceal bleed, but it should be considered only at the cost of high delayed morbidity. So this is another study again from AIMS, where they have shown that the previous studies have shown that the patency of the proximal splenomegaly shunt is around 85 to 90%. But this particular study has shown that the patency rate decreases over time. So it is around 64% at 1 year and 43% at 5 years. So what are the other options which can be considered for splenomegaly in non-cirrhotic portal fibrosis? So this is about partial splenic embolization. So this is the data from 6 patients in NCPF, where they have shown that there was significant improvement in the platelets from around a value of 10 to 12 to the platelets went up to around 170. But this response is also transient. So this is another data on partial splenic artery embolization, when the splenic artery was embolized to include spleen size of the embolization of around 60 to 70%. So this was the study in 26 patients, but this was a mixed bag of cirrhotics and non-cirrhotics. So again, but this is not free from various side effects related to fever, pain, nausea, or pleural effusion, pneumonia. So this is another option which can be considered for splenomegaly in patients with either NCPF or EHPVO. So this is a high intensity focused ultrasound. So where a frequency of 0.85 megahertz is given with a power of 300 to 400 watt over the splenic area, and so a therapeutic ultrasound is used just to ablate the spleen, to decrease the splenic size. So this is the data in 28 patients, again a mixed bag of cirrhotics and non-cirrhotics, and some of them were bleeders. So this particular study showed that there was significant reduction in the spleen size from around 1300 centimeter cube to around 950 centimeter cube. So there are the pictures. So, but this again is not free of complications. So there are abdominal pain, fever, effusion, and also skin reactions, the dermal ecchymosis, but there was no risk of splenic rupture, abscess, or peritonitis. Again, there is a comparative study on comparison of surgical splenectomy, partial splenic artery embolization, and high intensity focused ultrasound, which is also called HIFU. So the comparison was done, and this particular study showed that the technical success was there in almost all of the patients with where this focused ultrasound was used. And in comparison to the surgical patients or with the embolization, there was a relatively less operative time and less hospitalization. So the authors proposed that the HIFU causes coagulation necrosis of the spleen, carries fewer infectious complications, and so it is a relatively safer option for the hypersplenism. So what about shunt surgery? So which type of shunt should be done for particularly in the setting of EHPVO? Whether go for REX or to just go for the traditional shunts like PSRS. So as we all know, all the complications or all the events in the natural history of NCPF or EHPVO ultimately come down to shunt surgery, whether it is a refractory variceal bleed or growth failure or impaired quality of life or portal biliopathy. So, but what is the effect of shunt on the brain metabolites? So this is very interesting study again from SGPGI. So where it has been shown that those patients who undergo shunt, so they have actually higher blood ammonia, higher glutamine to creatine ratio, low myoinositol, and more risk of minimal hepatic encephalopathy. So with non-selective shunts, so there is risk of minimal hepatic encephalopathy and the changes in the brain metabolites, which are almost similar to cirrhotics. So again, this data also negates the effect of the shunt surgery. So in 25 PSRS patients, again from SDPGI, where the portal biliopathy changes have been shown that they are progressive in 6 patients and static in 19 patients. And also the density of the peribiliary collaterals increased in 3 patients and remained unchanged in 17. So portal biliopathy remains almost static. So what is the other option? So the other option is mesorex bypass, which is now in the guidelines that this should be the intervention of choice. It restores the hepatic portal blood flow in closest possible physiological manner. So this the studies have shown that there is with mesorex, there is improvement in platelet counts, and decrease in the splenic size, improvement in INR, improvement in blood ammonia. And so apart from restoration of the blood circulation to the liver, so it has additional metabolic benefits. So the complications related to EHPBO, that is hepatic dysfunction, growth failure, portopulmonary hypertension, hepatopulmonary syndrome, so they all revert. So overall, this is actually superior to the traditional shunts. So what are the available modalities to assess the Rex vein? So available modalities are ultrasound, CT and or MRI. So the CTAP, which is the CT arterial photography, has a sensitivity of around 100%. But in closest to CTAP is transhepatic photovenography or retrograde hepatovenography. So this actually is so we have to document. So whenever we are taking a patient for Rex shunt, we should document the anatomy on the based on retrograde internal jugular venogram. So there should be A-type anatomy of the patient. Then only the patient should be considered for a Rex shunt. So this is the anatomy. So this is a picture. So A-type anatomy means that both the right as well as the left and the main portal vein, the circulation is patent inside. So there is only extrahepatic portal venous obstruction. But in the other type, we can see here, either there is left side or right side or complete obstruction as in type E. So based on this, we have initiated one study at iLBS, where up till now 30 patients have been enrolled, where wedge hepatic photovenography has have been done. So, but out of 30 patients, we could find the patency of the Rex vein in just 4 of them. So that is the patency in our cohort of EHPVO is just around 13%. So our patients are not actually eligible for a Rex shunt surgery. So this I already said that the Rex shunt is actually better in terms of growth, portal hypertension, and minimal hepatic encephalopathy. What about, so this is relatively newer data. What about tips in EHPVO? So can these patients be subjected to tips? So this is the data from adults in EHPVO. 39 patients were taken. So the technical success was 100%, and the tips was done by a transjugular in 12, transsplenic in 19, and transmesenteric in 6 of them. And they have shown that the primary patency was around 63%, but secondary patency, this overall patency after a re-intervention, this angioplasty or restenting, was around 81%. Also, this tips in portal vein in EHPVO, that also is not free of complications. So there were risk of stenosis, thrombosis, fever, heart failure, hemoperitoneum, or rupture of the liver capsule. So this is this table actually summarizes the various studies of tips in chronic PVT, not typically EHPVO, but the patency rate they have mentioned that they vary from 40 to around 90%. What about portal vein recanalization in EHPVO? Can we recanalize the portal vein by intervention radiology procedures? So this is again a data from in 31 patients, again adult data and a mixed bag of cirrhotics as well as non-cirrhotics with median age around 50 years, and the indication being gastrointestinal bleeding or pain related to the EHPVO. So the transhepatic route was used in 30 of them, and in one patient, the transsplenic route was used. So this recanalization, this was the technical success was attained in 27 out of 31 patients, whereas in 4 patients this procedure failed. So failure of this procedure was associated with the extension within the intrahepatic portal veins, but the primary patency rate was around 73%. So this is the diagram which was mentioned, and this series was published in Hepatology last year only. So this was the anatomy before, And after the procedure, where the portal vein was recanalized with the stenting, and the procedure involved transhepatic puncture of the portal vein, recanalization, entry into the SMV and splenic vein, followed by measurement of pressures, doing a portogram, then dilating the tract up to 6 mm, and then placement of a self-expanding nitinol stand. And the same procedure when it is done by the transsplenic route, so that that procedure requires the occlusion of the access site just to prevent the bleeding. So what about parenchymal extinction in EHPVO and NCPF? So this is again a new concept, but the data is already there. So the basic thing is, because of the decreased portal vein blood supply, so there is tissue ischemia, cell death, and leading to atrophy of the portal tracts, subsequently leading to collapse and approximation of the portal tracts, which is one of the histological feature of NCPF. And with subsequent collapse, there is fibrosis, uh, and subsequently leading to parenchymal extinction and decomposition. So in EHPVO, the ascites is seen in up to 21%, whereas in NCPF, various studies have shown that ascites or decomposition is seen in up to 50%, and a proportion up to 20-25% may require liver transplant. So I will take just 5 more minutes on congenital hepatic fibrosis. So about congenital hepatic fibrosis, this is another cause of non-cirrhotic portal hypertension, which is related to ductal plate malformation, where there is failure of the involution and resorption of the ducts during the developmental process. So this is the normal development when the ducts are when a single duct is surrounding the portal vein. Whereas in DPM, there are numerous ductular structures which are dilated surround the portal vein. So again shown here. So various types: Carolese, CHF, CHF with ARPKD, with ATPKD, and or with one Meinberg complexes. So again, this morphological classification depending on whether the small, medium size, or large size intrahepatic ducts are involved. So this is shown here, like this large ducts, choledochosis, Carolese disease. Medium sized ducts are the polycystic liver disease, and small sized ducts are von Meinberg complexes and congenital hepatic fibrosis. So this is the data from so one is from India and one from Birmingham. So where it is shown that portal hypertensive presentation is the commonest presentation of CHF. Proportion around 20-30% present with cholangitis, but they again have portal hypertension. So this is a compilation of various congenital hepatic fibrosis cases published in JPGN in 2012. 1,200 cases where it was shown that ARPKD with CHF was the commonest presentation, that is 64%, isolated CHF in around 10%, and Carolese disease or syndrome was there in 25%. Also, the risk of cholangiocarcinoma was around 1.5%. So the renal disease is also there. So autosomal recessive polycystic kidney disease or autosomal dominant. So the renal disease and hepatic disease, so they are independent to each other. So there is no correlation between portal hypertension and renal disease. So various syndromes we should remember whenever we are discussing congenital hepatic fibrosis: Meckel-Gruber, Jobert, Bardet-Biedl, orofacial digital, and Alice-Van Creveld syndrome. So we should always remember to look for the retinal examination, CNS examination, echo, and a skeletal review to pick up these syndromes. Also to look for situs inversus, polydactyly whenever we are dealing with CHF. So some of the imaging pictures. So in CHF, so there is again just like a cirrhotic patient, there is hypertrophy of the left lobe and caudate lobe and relative atrophy of the right lobe. So the picture showing central dot sign, because the portal vein is surrounded by the dilated bile duct. So there is central dot sign. So one of our patient again showing the central dot sign. So enlarged kidneys, cystically dilated kidneys, biliary hematomas, von Meinberg complexes, very tiny cysts which are not communicating with the bile ducts. So histological picture. So the broad fibrous bands with cholangiolytic picture, and again broad fibrous bands. So we can see here dilated bile ducts. So DPM, ductal plate malformation. And this is one of our child where there are presence of nodules also. So later on, they may have a histological picture almost similar to cirrhosis. So how to manage? The portal hypertension is managed by endotherapy. Subsequently, some of the patients, there is evidence in the literature that some of these patients may be subjected to shunt surgery. Cholangitis is managed with antibiotics, and if there is associated hepatolithiasis, that is managed with by endotherapy. If there is partial localized Carolles, that can be managed with partial hepatectomy, and with hepatolithiasis can also be managed by ESWL. There is data on tips in congenital hepatic fibrosis. I could find 12 children from the literature. So this is the study on 5 children, 4 with ARPKD, and in 3 of them, tips served as a bridge to liver transplant. So transplant in fibrocystic liver disease, so various indications, it may be just a liver transplant or a combined liver or kidney transplant. So in ARPKD, it may be a renal or simultaneous liver kidney transplant, whereas in CHF, it is predominantly a liver transplant. So different indications depending on the different phenotype. If it is renal pathology which is predominant, so then the patient may be subjected to isolated or a simultaneous liver kidney transplant. Cholangiocarcinoma, as I already said, the proportion is around 1.5 to 2%, and the rate increases with increasing age. So finally, to summarize, I can say non-cirrhotic portal hypertension, we should suspect when there is splenomegaly, varices, variceal bleed, and preserved liver synthetic functions. So we should look for Doppler for patency of the portal vein or cavernoma. Biopsy is indicated for CHF and non-cirrhotic portal fibrosis. And so these patients are managed mainly by endotherapy. Shunt is indicated for ESPVO, but preferentially it should be REX. So we should should be looking for the patency of the REX vein, and then accordingly subject the patient to REX shunt. In contrast to proximal splenorenal or non-selective shunts. For NCPF, so there is the shunt. Even if it is indicated, that should be a judicial decision. And for congenital hepatic fibrosis, we should manage portal hypertension and cholangitis. Thank you.